So if LVI is present, or if so among those, if you ask which is most important, the most important is the LVI. Other studies have taken as a proliferation rate, and if the histopathological stage is more than T2, then it will be
आपके आने के पहले ठीक हो
नहीं हुआ तो उसके बाद नहीं करेंगे
बाद में इंडियन पुलिस के
so in histopathological stage, so that is very important when we see the stage 1. So if the patient is already a high tumor burden, already having a nodal metastatic disease, already having a lung metastasis, whatever present in the histopathological specimen in testicular tumor doesn't matter much. So in our PD, when residents are telling us that there is a lung metastatic disease, so irrespective of the component seen in the testicular tumor, the management will not change. So the most important part for a histopathological examination will be for stage 1 management, because that will decide. So LVI and the embryonal component, these are the, we will discuss how this factor comes into the. So men with testicular NSDCT and none of these factors are classified under low risk disease, that is no lymphovascular involvement and no or embryonal component less than 40%, that they will mostly come into low risk disease. Or the presence of one or more of these factors will denote the high risk disease. And what are the evidence for this? So in various studies, it has been seen that the presence of LVI alone or LVI plus embryonal component makes the disease high risk, and 55% patients will relapse at some period of time, mostly within 2 to 3 years. In contrast, the relapse rate in men without this factor are only 10 to 15%. So that means if we classify or risk stratify this one factor, which can help in deciding the subsequent treatment for stage 1 NSDCT. So for stage 1 low risk disease, surveillance is preferred if the patient is compliant and ready to adhere for a strict follow-up. For patient of stage 1 with high risk, that means with LVI or a embryonal component, what are the options? So there are again 3 options: surveillance, chemotherapy, and primary RPLND. We will discuss the pros and cons of each option in subsequent slide. So for stage 1 high risk patient, adjuvant short course of chemotherapy, that is 1 cycle of BP, is the preferred modality of treatment to avoid the 50% chance of recurrence at an unpredictable time in future. This is more relevant in our scenario where follow-up is not that strictly feasible as per the standard guideline. For patients who choose treatment but defer not to undergo adjuvant chemotherapy, nerve-sparing RPLND is another appropriate alternative, provided the technical expertise is available. That is very important. Surveillance is another option in well-informed patient, but usually we don't prefer, because 50% patient in a high risk category will relapse. So if we discuss the each and pros and cons of each option, surveillance for stage 1. So as I discussed that in high risk patient is not an option, because 50% patient, but the other side of the coin is that 50% will not relapse. We have to treat 50% patient who are not going to relapse in future. But the other side is that even if we follow these patients closely, in view of good results in over, so whenever these patients who are on surveillance, when we detect the tumor recurrence, if we treat with the effective chemotherapy, mostly with BP, the overall survival remains same in the range of 98 to 100%. So it is one of the options in well-informed, educated patient may be followed for a surveillance program for stage 1, even in high risk, but definitely you have to tell the pros and cons for this in group of the patient. So this is just a slide showing the patient who were put on surveillance. So the relapse rate is, I told you, around 30%, but the overall survival is 100%, because all those patients who are surveillance, if the recurrence is detected in a timely pattern, they are treated with effective chemotherapy. So the overall survival for even those patients who are surveillance is close to 100%. Then comes the RPLND, when we can consider RPLND. So RPLND can be used to accurately differentiate between stage 1 and 2 disease. It also significantly reduces the probability of systemic relapse. Relapse within the retroperitoneal field post RPLND occurs in less than 1% cases, and the overall survival is again same in the, even in those patients who are in a post RPLND. If there is a recurrence, they will be treated with effective chemotherapy. The survival remains same in the range of 100%. So what are the issues associated with RPLND? So the positive point is that RPLND has the potential advantage of removing the chemo-resistant mature teratoma. But the other side is the most significant long-term side effect is the retrogradation, because these are all young patients. We have to discuss about the quality of life in these. So this requires a high level of surgical expertise, which is difficult to get at community level. So if we are considering for a primary RPLND, the center should have adequate experience in doing the nerve sparing RPLND, so that the retrogradation can be prevented in this group of the patient. So same, if you see the follow-up for these patients who underwent RPLND for stage 1, the overall survival again, because even those patients who relapses will be salvaged with the effective chemotherapy. So now comes the third and most important, which is relevant, the adjuvant chemotherapy for stage 1. So as we discussed, the for a high risk, that is LVI present and embryonal more than 40 to 50%, we generally prefer 1 to 2 cycles of chemotherapy. So what are the plus minus point? There is the short-term toxicity. We all know that BP is a difficult region. Sometimes some patients end in complication. The only issue that as with the 3 to 4 cycle of BP, the long-term toxicity is still not very well documented in the literature, and there is a theoretically chances of complication with the what are the issues which are related with the BP? Some are dose related, some are dose unrelated. So infertility. So if we give 1 or 2 cycle of chemotherapy, the chances of, as we all know, those complications which are dose related, if you give the more number of cycles, the probability of getting that complication is more. So those patients who are getting 2 cycles, the probability of these complications like infertility, peripheral neuropathy, ototoxicity, Raynaud phenomena. So these are the complications which are associated with the more number of cycles of chemotherapy. So then the subsequent question comes whether to give 2 cycle is better or 1 cycle is good enough for these patients of stage of 1. So whether 1 cycle of BP is equal to 2 cycle of BP is not very clear. The largest study, which I will discuss at subsequent slide, suggests that 1 cycle of BP presents has a comparable results with 2 cycle of BP for stage 1 and NSDCT. So now we have gradually shifted from 2 cycle to 1 cycle, which for the reason which I explained in previous cycle, that the cumulative dose will be more and the long-term toxicity, because these patients are going to live for another 30-40 years. So we have to see so it's a balance between the efficacy versus the toxicity. So this slide which summarizes the 2 versus 1 data. If you see the relapse rate, definitely with the 2 cycles, the relapse is practically 0, wherein 1 cycle this is around 4 to 7%. But as again explained in previous slides, the testicle, because all those patients even who receive 1 cycle, when they relapses, the effective chemotherapy prevents the chances of cancer related in these patients. So the overall survival still again remains of the same whether they receive 1 cycle or 2 cycle. What are the evidence in favor of 1 cycle, we will discuss in the subsequent study. So this is one of the largest study done to answer this question. So this was a JCU paper. They look towards the risk adapted treatment in clinical stage 1 NSGCT, that is Sventoica management program. So the main inclusion criteria for this stage 1 study in this group of the patient. So treatment strategy depend on the presence or absence of vascular, that what I told you, LVI or vascular invasion. So patient who are LVI present were received brief adjuvant chemotherapy with 1 or 2 cycle, whereas those patients who are LVI negative were given the option of a active that 1 cycle of chemotherapy or surveillance. I will explain in the subsequent slide. So in this study, all patients of stage 1 NSGCT with LVI, because in this study the risk stratification was based only on the LVI. So patients who were LVI positive were either received 1 cycle of BP or 2 cycle of BP. Patient of stage 1 NSGCT without LVI, either they underwent observation or 1 cycle of BP. Few patients of LVI also opted for surveillance out of the protocol. So LVI positive patient 1 cycle versus, so the question of in lymphovascular invasion positive were 1 versus 2 cycle. In LVI negative, the question was surveillance versus 1 cycle of BP. So they try to look to the answer for this question. So what they concluded in this study, that after 1 cycle of BP, around 3% of the patient with LVI and around 1% patient of the LVI negative relapse. And the toxicity of adjuvant BP of 1 cycle was very low. So in conclusion, the one course of adjuvant BP for LVI positive reduces the total burden of chemotherapy compared with the surveillance or 2 cycle of BP. So if we are keeping this patient under surveillance, since it's a LVI positive, there is an increased chance of relapse. But if we give 2 cycle in this group of the patient, the toxicity will be more, and the chances of recurrence with 1 cycle is around 3% compared to the around 1% who received 2. That I will explain in the subsequent slide. So this is the relapse-free survival percentage of patients who are going to relapse. So as I told you, the division was without vascular invasion and with vascular invasion. So this yellow line is for the patient who underwent surveillance in patient LVI negative. So patients who were on the surveillance in LVI negative, 86 around 87% patient were recurrence free at the follow-up around 8 to 10 years. Whereas patient who received 1 cycle of chemotherapy, even with vascular invasion, close to 99% patient, around only 1 or 2% relapses. So even in patient with vascular invasion negative, if you give 1 cycle, practically those patients are get cured. Now the question comes that is more important for us: patient with lymphovascular invasion who are at high risk of recurrence, around 50% will relapse, whether 1 cycle or 2 cycle. So these are the two. So this blue line is for the 2 cycle of BP, and this lower one is for 1 cycle of BP. So if you see this patient who received 2 cycle of BP in lymphovascular invasion positive, no patient relapsed even at follow-up around 10 years. But in patient who received 1 cycle of BP, this percentage comes down to, so the difference is only 4%. Patient who does not lymphovascular invasion positive and has not received any treatment, there is around 40% chance of recurrence. So that is giving 2 cycle practically cures the patient, but giving 1 cycle, the difference is only, and we can avoid the chemotherapy for 1 cycle in majority of the patient, because the difference is only 4%. So with additional 1 cycle of the chemotherapy, only 4% additional benefit in preventing the recurrence, which can be further detected by the close follow-up and can be prevented. So majority of the patient with even in LVI, 1 cycle is good enough. The difference is only 4%. So that means 1 cycle has also very good disease control rate compared to 2 cycle. And definitely with LVI, if we keep the patient under surveillance, 40% will relapse at some point of time. So this paper was in around 2005. Then the question comes whether what is the data for long-term follow-up. So this was, I think, around 2. So after another 4 or 5 years, the same group followed up these patients, and in 2014 they presented the long-term follow-up data. So data for patients who received 1 cycle of BP are presented in this study. So they concluded that the relapse rate at 5 years was around 3.5, it's around 3% for patient with LVI with 1 cycle of BP, and around 1.65% for patient with LVI. So that means with 1 cycle of BP, even in long-term follow-up, only 3% patient will relapse. And with due course of time, we have already changed our schema of treatment. So in patient with high risk, we consider for 1 cycle instead of 2 cycle with the long-term data. So now the only question comes, whether is there any randomized trial which compared the, because RPLND is another option. So has it been compared with the RPLND versus 1 cycle of BP in this scenario, stage 1? So there is one randomized study of around 380 patients which compared the primary RPLND versus the 1 course of BP. So the result of this study again showed that the difference in 2-year recurrence-free survival between chemotherapy and surgery was 7.59%. So the patient who underwent, and the other important point of this slide is that there is a hazard ratio to experience a tumor recurrence with surgery as compared to the chemotherapy was as high as 8. So that means patient who underwent surgery, there is a quite lot chance that the patient will get a recurrence compared to who receive only 1 cycle of chemotherapy. So this is the graphical representation, the recurrence-free survival and over period of time. So patient who received 1 cycle of BP, you see this is practically a flat line over due course of time. But patient who underwent RPLND, this graph dips and this will, so that is patient who underwent RP20 for stage 1 stage disease, there is a 8 to 10% chance that there will be a recurrence over course of time. Compared to patient who received 1 cycle of BP, patient is practically great, which is seen in the other data from the other. So that means 1 cycle seems to be adequate for stage 1 high risk NSGCT. So the prognosis of a patient with stage 1 non-NSGCT is very good. Some of the patient relapses with metastatic disease after arteriectomy. Adjuvant treatment in the form of either chemotherapy or RP20 is recommended, especially in high group. Active surveillance has been found to be a good way in treating those patients with excellent result, but definitely in a well-informed, educated patient, especially in low risk. Practically, we rarely see a low risk in NSGCT in our setting. Most of the time, we see a disease which is on the slightly on the higher stages. So NSGCT is stage 1. If the patient opted for surveillance, and then if there is a relapse, they will be treated with 3 or 4 cycles as per their risk. Patient who opted for risk-adapted management. So the most important risk-adapted management is the presence of LVI plus or LVI minus. Patient who have a LVI positive, the first treatment or standard treatment is the 1 cycle of BP. When the patient does not want to undergo chemotherapy and still wants some treatment, nerve-sparing RP20 is the preferred choice. And if patient doesn't want those, then patient can be considered for surveillance in high risk. And this sequence will be reversed in a low risk. The surveillance is the preferred choice, followed by adjuvant chemotherapy in patient who does not want to take any chance of around 15 to 20%, and then the NSRP20. So this schema, what we follow in day 2, we definitely take the other important risk factor, that is if the embryology is more than 50%, we take the same protocol or follow same path for the management of these patients. So this is for this stage 1 NSGCT. Time, should we go for a Seminoma? Thank you. Okay, so we'll finish in 10-15 minutes. So that was for the NSGCT, and as I told you, for stage 1 with the histopathology, we have to show whether we are dealing with the NSGCT or Seminoma, because the management is entirely different. So if the tumor markers are normal, the pathologist has clearly written in the report that it is the Seminoma, and there is no disease elsewhere in the abdomen. Then the question comes how to treat the stage 1 Seminoma. So as again in in the previous NSGCT, there is also 3 options: RT, carboplatin, and surveillance. So RT, which was most commonly used earlier, carboplatin, which we do most commonly at our setting, and definitely surveillance. The data for surveillance is much more stronger in Seminoma compared to the NSGCT, which is most commonly advocated currently. So we will discuss quickly the pros and cons of each of the options. So before this TE19 trial, that was the carboplatin trial, RT was the standard treatment. So what are the treatment, the toxicities or problem associated with the RT? So second cancer, which is it's a well-known deeded, but definitely there is a small definite risk of second cancer, and there is some data which suggests that these patients, the relative risk of developing a second cancer for a which is non-testicular malignancy was 2 times more common for those patients of a Seminoma treated with the para-aortic artery. The second complication is the cardiovascular complication, and there are 2 studies which have shown that the relative risk for cardiac mortality is around 2 times more common in patients who are treated with the RT compared to the general population. So that means the long-term complication of a RT is there, especially the second cancer and cardiac complication. As I told you, these patients are going to live for another 30-40 years. So these complications definitely makes a point whether to consider this or any other alternative treatment strategy. So what are the so in the initial phases of this, the radiation onco various groups try to reduce the radiation toxicity by reducing the field, by reducing the dose, which we'll discuss subsequently. So the traditional planning, I think most of the residents who have a radiation background, they know that the initial part, the management for stage 1 patient was what we call as a dog leg field, which covers both para-aortic and pelvic. So this is a shape like a dog leg. So the dose is around 30 gray with 3 to 4 weeks. So they covered both para-aortic and pelvic in this area, and the dose which was initially used is around 30 gray, which goes for 3 to 4 weeks. So then they thought, can we cut down the field? So this was the first modification in the field size, and this was the MRC trial where they compared the para-aortic field versus the dog leg field. So they cut down. So the radiation field will be up to this in this group of the patient, and another the standard will cover the pelvic lymph node also. So what they concluded from this study that the recurrence-free survival in the para-aortic field was around 96% compared to, so that means the reducing the field has not impacted the recurrence. So with this MRC data, the para-aortic field radiation become the standard of care at that point of time, and this they concluded that there is no extra benefit of adding the pelvic node in and we all know that the lymphatic drainage for testicular cancer mostly in the para-aortic, treating pelvic is not going to help much. The second trial what they did, they tried to compare the dose was in the previous study was also 30 gray. So in subsequent MRC TE18 trial, they compared the 20 gray versus 30 gray. The field will remain same. So the standard dose was 30 gray para-aortic. The test dose was 20 gray 10 fraction. So they tried to look whether the reducing dose have an impact on the recurrence. So what they in the same this study, they concluded that the 20 gray radiotherapy with the para-aortic field has a similar recurrence compared to the 30 gray. So with this TE18 trial, this para-aortic field with the 20 gray becomes the standard of care till that point of time. So then and definitely this trial also shows that patient who receive 20 gray has a better recovery. They come to the job early. We all know that if we reduce the dose, the subsequent complication comes down. So with this, the 20 gray para-aortic field becomes the standard of care at that point of time. So now comes our area of interest, that is the carboplatin story. So simultaneously, various phase 2 studies have indicated that the single agent carboplatin is a very good effective option and in preventing the recurrences in this patient. But there was a phase 2 data which suggested that this led to another randomized trial in this scenario. This is the MRC TE19 trial where they compared in a stage 1 seminoma, they compared the single cycle of carboplatin versus para-aortic lymph node radiation of a 20 gray. So this was a non-inferiority design. The patient number were around 1500 patient, and they were followed up around. So the first paper was published around 2006 or 7. This was a follow-up data. So it's around 10-year follow-up for patient who the median follow-up for this study was around 7 years in 2011. So one cycle of carboplatin versus para-aortic lymph node radiation of 20 gray. They randomly compared these two studies. So this is the schema of TE19 trial. Around 1500 patients, 570 and 904. There was a second randomization at this, so we will just leave it for our discussion purpose. So half of the patient received the carboplatin, and this group. So they compared this versus this. That is 20 gray versus 573. So the most important part for the carboplatin is this: that the dose of carboplatin in this study, they calculated the GFR by EDTA or a comparable isotope measurement technique. It's not the usual Cockcroft law formula which we take. When this was not available at any center, the other alternative, but they found that the urinary 24-hour creatinine clearance, but not a calculated GFR by Cockcroft was used. So that is important for us, that when we plan the carboplatin dose in a stage 1 testicular, we should send the patient for the DTP which is available at our center, and the GFR dose to be calculated not from this calculated formula, but it should be from the EDT which is available at our center. So coming to the result of this trial, at around 7-year follow-up, so they compared if you see the relapses, so it's around 5% versus 4%. So this was a non-inferiority trial, and the result of this trial concluded that carboplatin, single dose carboplatin at UC7 is non-inferior to RT in stage 1. If you see the other points of this study, so it's around 5% relapse versus 4%. Numerically, it's also more or less same. Death from the seminoma is practically nil in the carboplatin compared to 1. Death from other causes, it's around 6 compared to the 9. So that means in terms of the other unrelated death, the carboplatin is not worse than the RT, and both I have the death complication more or less remain in both the group. This is another important and positive finding in favor of carboplatin was that when they look towards the incidence of contralateral testicular cancer, so there is 1 to 2% chance of a contralateral testicular cancer developing in testicular patient on subsequent follow-up. So in a day-to-day practice, we generally consider yearly USG scrotum for these patients on follow-up. So that was the additional positive finding in the carboplatin arm. If you see the incidence of contralateral testicular cancer, it is hardly nil, it's around 0.3%. Whereas if you see the chances of contralateral testicular cancer is around 2%. So the probable hypothesis is that with the carboplatin, some patient who might harbor the carcinoma in situ might be getting treated with the high dose carboplatin and preventing the subsequent testicular cancer relapse. So this number is around only 2 and it is 15. So that is one of the additional positive point in favor of the carboplatin, that it also reduces the chance of contralateral testicular cancer in follow-up. So that I told you, if you see the graph of this, they are mostly parallel. The recurrence-free survival at 5 years, it was around 96% in the radiation and around 94%, and the difference is around 1. And at the time of hypothesis, if it is less than 3%, it was expected. So this has led this trial, result of this trial has concluded that the carboplatin can be option for a stage 1 testicular cancer compared to the radiotherapy, with this added advantage which I told you. The only negative point or only controversial point is the non-inferiority design, which have been discussed in multiple forums, but we all know that this is the accepted treatment modality. So these are the some series which have shown recurrence risk in this patient. So these are the retrospective series, around 1,000 patients of the 5-year patient who were on the surveillance. In this, around 20% patient will relapse without any treatment, but 5-year disease survival is again 100%, because all those who have relapsed will be treated with effective chemotherapy. Patients who receive 2 cycles of carboplatin, practically the relapse rate comes down to less than 2%. With radiation, it's around 3%. And similarly, the 5-year survival remained more or less same, whatever modality we use. So the other question comes into day-to-day practice, whether to give 2 cycles of carboplatin or 1 cycle. Because in this study, 1 cycle was given. If we compare the long-term data of 2 versus 1 course of carboplatin, if you see the relapse rate, it's around 2% in patients who receive 2 cycles of carboplatin, and it's around 5% in patients who receive 1 cycle of carboplatin. So in a day-to-day setting, if the patient has tolerated first cycle very well without any grade 3 complication, patient is willing, we might consider for second cycle, but that is an optional. 1 cycle is must, second cycle is an optional. If the patient has developed any complication of first cycle, we generally don't push for the second cycle of carboplatin, because 2 cycle has shown that but only thing is that we don't know the long-term complication of the second cycle of carboplatin in this group of the patient. But in a fit patient, we consider 2 cycle. Otherwise, 1 cycle is the standard answer for this stage 1. If you look towards the toxicity of the 1 cycle of EOC7, definitely, as expected, the grade 3 toxicities are few patients may get thrombocytopenia. We all grade 4 that we know that carboplatin can cause. So whenever we give this high dose carboplatin, we call the patient on day 7 and then again on day 40, just to be sure that we should not miss, because we don't want to lose the patient with this toxicity. These are the practically curable patients. So whenever we give 1 cycle of carboplatin, we have to follow the patient very closely, day 7, day 14, and if count recovers by day 20, then we send the patient, because 2% will be 100% for some patient. So we have to be careful with this. But in our day-to-day practice, we have not seen any life-threatening complication on it till the time we are using the carboplatin in this. So this is another comparison of radiation versus carboplatin. So as the radiation that goes for around 10 to 15 days with Saturday Sunday gap, so it's around 14 days. Whereas the more missed were moderate to severe lethality, more. So if these are the toxicities associated with. The only concern for carboplatin is that the thrombus. If you can take off this, definitely carboplatin is in statistical terms it is not non-inferior to the radiotherapy. So carboplatin advantage is simple outpatient treatment, low toxicity, effective. The only question is that long-term toxicity of carbon. That the paper that I discussed, that was a follow-up of around median follow-up 7 years, which I think is a good long-term follow-up for any cancer-related long-term complication. The only issue is that in a peripheral center where this facility is not available DTP, so the other alternative option is to go for a urinary creatinine clearance calculation, but it should not be done on the Cochrane formula. Now, so third option comes the surveillance. So we have discussed the radiotherapy, we have discussed the carboplatin. Is there any role of surveillance? Definitely. So the only problem of the compared to the NSACT, where there is a marker in majority of the cases, but we cannot rely on LDS for surveillance. So that is one of the difficult point for following keeping the patient for surveillance in NSACT. There is a lack of tumor marker. Only thing is that those patients will require more strict follow-up and defining the high risk versus low risk as we discussed in NSACT. So why we are discussing surveillance, because as we have seen that even if we do the architectomy alone and don't do anything, 80 to 85% of the patient will not relapse. So that means the treatment is required for only 15 to 20% patient, and we are over treating the rest 80% patient. So is there any way to differentiate between high risk and low risk? So that what I again give for all testicular cancer for stage 1. If we follow these patients, the cause specific survival is 100%, because all those patients will be effectively. But the most important point that the surveillance protocol for these patients are more strict. Patient needs to come for follow-up very closely. They should not miss the follow-up. That, and in a hospital like Tata, it's difficult to explain, but definitely in a well-educated patient that can be considered. But for a patient who is coming from a very far, first time he has reached the hospital, better to give him some treatment and then send him back. Even if he doesn't come for follow-up, practically he will be cured. So we don't go for a surveillance in a patient who is not very much keen and not want to come for a strict follow-up. So is there any way to risk stratify stage 1? Yes, definitely. So this is one of the paper. So they looked at the various histopathological feature and long-term survival for these patients. So they what at all, they define the following tumor characteristic for a risk stratification and their chance of recurrence: size, histopathological subtype, invasion of testis, tumor invasion, age, and diagnosis. So what they concluded from their study, that the chance of recurrence, if the tumor size is less than 4 versus more than 4, the chances of in patient who have a tumor size more than 4 centimeter, there is an increased likelihood of recurrence. Rest other age, small vessel invasion, histopathological type, these criteria doesn't differ in relapse versus non-relapsing patient. The other important point, they conclude that the involvement of the rated testis was 6. So they concluded that if the tumor size is more than 4 centimeter, if there is a rated testicular involvement, the chances of likelihood of recurrence is very high. So this is the graph saying same thing. This is the patient tumor size less than 4 centimeter, chance of recurrence, compared who has more than 4 centimeters. So definitely patient more than 4 centimeter has a more chance of recurrence. Around if you see around 6.6 for every 60% patient. Similarly, rated testis involvement, if there is a rated testis involvement present, the more number of patient relapses in phase. So this was a retrospective study. So what they concluded, that if there is no risk factor, that there is no size is less than 4 centimeter, no rated testicular involvement, the 5-year relapse rate is around 12%. If there is a one relapse risk factor, the chance is around 15%. If there are both factors, that is more than 4 plus rated testicular, the chance increases to 30%. So that means the 30% patient will relapse. But the only point of controversy is that this was a retrospective study was done, but that is the best evidence which is available at point of time. So is there any study which is based on the risk adapted treatment in clinical stage 1? So this is the only small study in which this is a Spanish germ cell center study group. So in patients who have a tumor size more than 4 centimeters, so patient who have 0 or 1 risk factor, patient underwent only surveillance. Patient who have both these factors, they received carboplatin. So what they concluded, the only this was a study with a short follow-up. So they concluded that adjuvant carboplatin seems adequate treatment for patient with the 2 risk criteria, and acute surveillance is for patient with 0 or 1 risk factor, depending upon. So this is the only one small study based on the side. So what are the other points against this? So this is what the European urology paper, which so the main issue is in the defining the rated testicular. If you discuss with pathologists, it's very difficult to define the involvement of the rated testicular invasion or not. So for a patient at tertiary care center, still patient who are dealing or pathologists who are dealing with the uropathology, they are still, but in a community setting, whether the rated testicular is involved or not, that it's very difficult to ascertain by a community pathologist. So what they European this guideline concluded that that the available evidence on the prognostic value of tumor size and RTI in stage 1 seminoma has limitation and should not be used in clinical practice. But this was their recommendation. But in day-to-day practice, we find this useful, and we are using, at least for those patients in whom we want to keep under surveillance, we see these 2 factors in there. But in Western guidelines, surveillance is now the standard option. Because the chances of, because it avoids the treatment in 80% case, only 20% patient will recur, and those recurrence will be treated effectively with salvage therapy. So the carboplatin option that we prefer, 1 versus 2, I told you. The only thing is the long term, that means 20-year data is not available, but 7-year data is available. RT option that now practically has gone out of the practice because of it. But if you discuss with the radiation oncologist, they will definitely come with some point that, if you go to the guidelines, practically even the European urology guidelines, they say that the adjuvant RT is no longer considered in stage 1. The carboplatin seems, the first is surveillance, followed by carboplatin, followed by RT. So that has come down into the, so this is the final slide. So for stage 1, after arachidectomy, confirm whether it's a GCT or not. If there is a Leydig cell tumor or Sertoli cell tumor, then these all will go on. Whether it's a seminoma, then whether it's a seminoma or NSGCT, after confirmation of GCT, then confirms whether you are dealing with stage 1 disease or not. If there is a nodal involvement, then all this doesn't apply. If the tumor marker is high, then all it will not apply. Then after confirming this is stage 1, then decide whether it falls into the low risk or versus high risk. And for defining the low risk versus high risk for seminoma, we take the tumor size more than 4 centimeters, invasion of rated testis. For non-seminoma, as I told you, lymphovascular invasion and the embryonal component. So patients of seminoma with these 2 criteria are high risk. NSGCT, these 2 criteria, they are at high risk. And for stage 1 seminoma, that I told you, surveillance, this is the European urology guideline. Surveillance is the recommended management option if facility available and patient is compliant. Even they have given this caveat, which is not there in our scenario. The patient is compliant in general OPD, we all know that. So we do some patient, but definitely the most important message is, if you are keeping the patient under surveillance, a follow-up chart should be handed to the patient and their relative, and that should be documented that we have, because patient will not come for follow-up and then will say you have not called us. So there should be a surveillance protocol attached to the file and 1 copy given to the patient and explain to the family member that you have to come at this point of time, every 2 monthly or 3, whatever whether we are dealing with seminoma or NSGCT. The second best is carboplatin AOC 7, 1 versus 2 cycle. We consider 2 cycle if patient is tolerating. Adjuvant treatment is not recommended. I told you, so less than 4 centimeter, no rated testis involvement, we can consider for the surveillance also. Radiotherapy is not recommended. They concluded, but in some patients where the renal function is hampered or some other contraindication for, and the patient does not want, we can consider for para-aortic artery in those group of the patient. For NSGCT, again I told you we have to decide between low risk versus high risk. PT1 and no vascular invasion are low risk. Surveillance is the preferred strategy. If patient does not want to for surveillance, then 1 cycle of BP is standard. If patient does not want to go for this and there is a high expertise for RP90, then the non-sparing RP90 is one of the options. Patients who are at high risk, that means the LVI present and renal more than 40 to 50%. The primary chemotherapy with 1 cycle of BP is the standard of care. And these are, I told you, these will go the reverse sequence of the chemotherapy will come into the picture. So just only last 2 slides. What is the development which has come in last 2 to 3 years? So this is another very potential marker for follow-up. So this circulating microRNA, that these are the 2 microRNA which can be detected by RT-PCR technique. They are overexpressed in testicular cancer and are very important that they are negative in normal tissue teratoma and other cancer. These are the potential universal biomarker for both seminoma and NSCT. The level of these miRNA correlates with tumor burden and are decreased after surgery and chemotherapy. So the current trial which are going for stage 1, they are taking one of the important endpoint for microRNA. So in due course of time, say after 5 or 7 years, the guideline may change. Patients who are persistently positive or where the microRNA level is increasing. So that is the future for stage 1 management of these patients. The other thing which have come, I think, which we have discussed in our general clinic also, this is that. So the question comes for patient stage 1 patient will require very close follow-up with CT scan, 6 months, 12 months, 18 months. So this UK group, they try to compare the follow-up schedule with 7 CTs versus 3 CTs versus 3 MRI. So we all know that these patients 6, 12, 14. So these patients will have to go multiple CT scan with definitely a theoretical risk of radiation in long term, and we don't know how these patients, even though small radiation can cause long term complications. So they compared 7 CTs versus 7 MRI versus 3 CTs versus 3 MRI. And what the result of this trial concluded that surveillance is a safe option, and the instead of this more frequent staging either by CT or MRI compared to the 3 CT versus 3 MRI, the chances of recurrence is around 7% in a 6% way. So what they concluded that MRI can be recommended to reduce the radiation risk, and there is no adverse impact on long-term outcome was seen with reduced schedule. So I think with this study, we are trying to change our also follow-up. So for stage 1 patient, if we are keeping under patient surveillance, the CT is not required, we can consider MRI, and even with this trial data, even the 3 MRI at the 6, 18 and 36 month will be as good as compared to the 7 CT or MRI. So that is one of the recent development which has been presented. So this is another slide that statistics can be confusing. So you cannot conclude that people who have a cat will get if you put a graph, you will get a correlation coefficient that patients who have a quad will get stuck by a lightning. But the statistics, the software can give you anything. We have to decide, and we have to make a balance between the efficacy. At least if you see all other Hodgkin lymphoma, the ALL, the world has shifted towards the reducing the toxicity, because we are already closing close to the cure rate of 90-95%. So balance is the everything in life. Thank you. So any questions? Dr. Kumar, if you have to add anything for this statement.
Sir, how many years you consider for active surveillance?
So the guidelines for NSCT, there's in general 5 years is the recommendation. Some guidelines say that seminoma you can stop at 3 years, but in day-to-day practice, we are calling the patient for 5 years, and I personally tell them to at least come for over 10 years, at least once yearly. But by guideline, 5 years is good enough time for certainly, because most of the time the recurrences which you usually it happens within two years. The only problem with seminoma, because we have seen some late recurrences after 10 years in seminoma. So some seminoma have a tendency to do late recurrences, but 5 years is good enough from the guidelines. And the most important point which I forget to say, all patients who are planning for some treatment for stage 1 should be sent for serum analysis, and because of the young patient, we don't know how the complication of even single dose carboplatin will be there on sperm analysis. So as a routine, we send all patients who are unmarried or married and want to have a family in future. By default, the serum analysis and banking should be considered in all patients. Yes, it's required. We don't know how the EOC 7 will have impact on the sperm analysis. Then there is no harm in doing the sperm analysis and banking if the number remains good. These studies have not shown. I think they should also show the long-term data of the what was the after 5 or 7 with one. So that was the only negative point with the carboplatin, that the follow-up data for 7 years. After 2011, they have not updated the long-term data, but the median follow-up that study was already 7 years.
Sir, I also needed to ask whether we treat the on-relapse asymptomatic serological rise. Do we treat these patients when stage 1 patients comes on?
Yes, if the tumor markers are rising, that is the definition of stage 1S. 1S means that the tumor markers are rising or still on the higher side. But on imaging, you don't see any disease. You have done a CCT thorax abdomen.
Yes.
There is no disease in that.
Yes.
But beta SCG is rising from 50 to 100. So that will come under 1S. So that will be treated like stage 1 with 3 BP or 4 EP. But definitely we don't chase the LDH, because LDH is the most difficult tumor marker to be. So if only LDH is rising, we don't consider LDH as the tumor marker. We have to be careful taking the LDH as a marker for deciding the treatment or even recurrences. So most important is the AFP in beta. LDH is just for the staging purpose at the time of diagnosis, but not for decision making in this follow-up scenario.
Sir, in stage 1S is the S3 markers, so they should be with the 3 weeks or 4 weeks.
So generally, it's very rare for a stage 1 patient without any radiological disease having a tumor marker in the S3 range. You have to wait. But I told you, for stage 1, this Sventrica group, they waited for 6 to 8 weeks. So if the tumor markers are falling, they have done tumor marker every weekly. So if the tumor markers are still elevated after 6 weeks, and there is no disease, then that will be level. So I have not seen even 1S. I think we have rarely 1 or 2 patients we remember in a year that we see 1S, and most of the time the tumor marker will be in range of. So if there is a S3 marker, we should try to look for the other side, like we have to go for MRI brain to know whether there is. So it's very rare for 1S to have S3 marker, but if it is there, then definitely you have to go for a foresight.
So Amit, gonadal versus extragonadal tumor. So is there a germ mass versus pluripotency which is decided inherent to a particular cells or environmental, how it is?
So if you go to the pathophysiology, that is 11Q, I think I was just calling the name, the 11Q. So all 11, 12. So if you see the original cell of a germ cell, all this should have a that. So that even the extragonadal germ cell tumor has that 12Q in deletion in that. So that it denotes that the origin of this testicular germ cell tumor is not dependent upon that. Is a genetic event because of the persistence of this 12Q marker. So that's why we see sometime in the mediastinum, also in the abdomen also. So it's a particular genetic change. If it happens into the testis, it will be level as a testicular germ cell, or if it happens in an abdominal node without anything, it will be a retroperitoneal germ cell, and it happens in the mediastinum. But mediastinum definitely have additional genetic event. That's why it makes the disease more resistant to the treatment. It is associated with other non germ cell component like the secondary malignancy, the polycythemia. All these are also associated with that. So mediastinal NSGCT have additional genetic event apart from the distal.
So sir, this CT thing, like small nodes in the CT scan, maybe in stage 1 small nodes or
it's very controversial.
When do you decide biopsy versus MRI?
So what the recommendation is that anything in the retroperitoneum. So there is a paper which compared the size of the lymph node vis-a-vis the chances of a disease in that. So what they concluded and what we do in practice, radiologists, they will write sub-centimeter. So I told when this reports come, I want to know the exact size, whether it's a 9 mm or 7 mm or 5 mm. So the what the cutoff which has been used is around 7 mm. If any retroperitoneal lymph node in a draining lymph node zone in a testicular tumor which is more than 7 to 8 mm size, we have to take it as a positive until proved otherwise. So even not 1 centimeter. So there are various sensitivity and specificity they have applied from the site point of view. The question is that in retroperitoneal lymph node in a stage 1, what size we should consider as a positive or not. So what the literature is on 8 mm. So we usually take it a little more than 8 mm.
So MRI versus CT or doing a follow-up scan.
So sometimes if the tumor markers are normal and lymph node is only around 8 mm and there is no as such high risk feature, we generally keep the patient under close follow-up. We repeat a scan after 8 to 10 weeks. That we do. If there is a high risk feature and 8 mm no, that is most control. So the management of that will be under heading of stage 2A. So 2A treatment has also evolved. So some 2A of NSGCT, there is one school of thought, if the tumor markers are normal and there is a lymph node which is less than 2 centimeter, you can go for primary RBND, check the histopathology and then go give them chemotherapy. If the tumor markers were elevated and now started falling down, you can directly go give them the chemotherapy. So 2A is evolving. Similarly for stage 2A seminoma, there is a data of high dose carboplatin. Like an Hodgkin lymphoma, assess the response, responding, give one more cycle of AUC 10, and the other group who is not responding can go for a big BP. So 2A for seminoma and NSGCT is
how many times you have biopsy done?
No, I don't remember कि कभी हमने 2A में biopsy कराई हो.
Because of the size.
Yes.
What is the growing teratoma syndrome? I'm trying to recall them.
Yeah, growing tumor symptom. So after completion of chemotherapy, that is more applicable for NSGCT. So there is a 4 or 5 centimeter abdominal lymph node, paraortic lymph node to start with. So to know whether it's a that's a fibrosis or viable disease or fibrosis, we need to resect the disease. If we keep the teratoma, there are 2 complications which can happen. In due course of the time, the teratoma will grow locally and can involve the surrounding structure like ureter, bowel loop. So that will call it a growing teratoma syndrome. The other complication of keeping the teratoma that it's a pluripotent with both ectoderm and endoderm. So sometimes these have a differentiation into the most commonly is the GIV which we see. So sometimes the patient comes after 8-10 year history and then abdominal loss. When we do the biopsy, we will find there is adenocarcinoma intestinal component. So the long term, after 7 or 8 years, they may transform and then they metastasize to the other organ of the body. So both the teratoma needs to be removed for preventing the growing teratoma syndrome, and second to prevent the chances of some malignant transformation in future.
Is there a time cutoff for tumor markers to normalize? As you said, we can wait till 6 weeks.
Yes. So that was the most controversial area. I have read a lot, and ultimately, when you read this paper, if you want to read, I will send you the JCO paper. They have waited. If the tumor markers are falling every weekly, there is no disease in the abdomen, 6 to 8 weeks per day. But for us, 8 weeks will be too enough. So I usually 4 to 6 weeks, what we consider, provided other things are in the line. So if there is already LVI is present and we have decided to give chemotherapy, so but 4 weeks you can safely wait. There is no doubt. Literature says 6 to 8 stage 1.
And for if for any patient we give one cycle of BP and the patient relapses, suppose, can we rechallenge it?
Yes, so the 4 BP you can give. So so therefore the cause specific or the overall survival in all the series, whether you have done surveillance or chemotherapy or radiation, or will reach 100%. All those patients who relapses will be treated effectively with the therapy. So survival will remain more or less. But definitely we have some patient may be spare of the treatment now. Like in a seminoma, 20% will only relapse. But if you have to give carboplatin RCT, all 100% patient, so 80% patient will unnecessarily receive now.
So this RT and cardiovascular
Complication.
that is something interesting because I couldn't find any others.
They will so they will argue whether these are the data of a technique where they used to give the AP portal, that cobalt technique. But even with there was one point which I have not highlighted. Even with the IMRT, they tried the doses given to that particular point. That was more or less same. So if we believe that this toxicity because of the IMRT doses for that particular region is same, so we can argue. So that will depend upon which side you are. If you are on our side, you will see that. So that debates on
RT to that reason, like in sarcomas also RT is given, like so in sarcoma. So like in some lymphomas also we give RT, but I have never seen that cardiovascular outcome or mortality.
So what they are the hypothesis is that the radiation can cause the intimal large intimal damage, which might provoke the
cardiovascular.
Yes. So exact cause is not known how the radiation
field is quite large, probably.
Yes, this is the
unlike sarcomas where we have focal areas. I don't
yes, that may be one. I don't know about the long-term complication of RT in Hodgkin patient treated with Hodgkin.
Yeah, because that is mostly the mediastinum.
Okay, so
blood causing
I think aorta, that may be the reason is long length of aorta comes into the picture.
Yuvraj Singh had what anesthesia?
No, Yuvraj Singh has a seminoma, mediastinal seminoma.
What treatment got?
Exam ले रही हो
Maybe they get it. Ask this question.
BP. He was surprisingly he was treated with BP. I was really surprised. I normally treated him with 3 cycles. We know he just player. So other name which is Jyoti wants to add that 2 or 3 names we should remember the cyclist Lance Armstrong. He was one of the survivor ultimately, but somehow
he was a survivor of different kind.
उसको उसके 4 से भी प्रूव हो गया क्या? He was the winner of a Tour de France. Yeah, 7 times winner, and he has written one book also.
Yes.
So that is gold medal question. I don't remember the name of the book. And the scientist, which is or the physician, that is like Einon.
It's not about the bike.
Yes, it's not about the bike. Right. It's not about.
It's journey of my life.
So in the NPI positive, use stage 1 NSCCP. You said only 1 cycle of BP and not 2 cycles. With 2 cycles, we are reaching 100% survival.
But the complication of it, if you give the 2 cycle of BP, the etoposide dose will be quite, it will reach around 800 or 900. There may be theoretical possibility of leukemia in those patients. Cisplatin, so all those toxicities which are dose dependent, and the benefit, the absolute benefit of 2 versus 1 is around 4%. So with one cycle, 97% patients are disease free. With 2 cycle, 100%. So just to additional 3%, you have to give chemotherapy to all patients. 1 more cycle, which is associated blue. फिर 3 और 2 में डिफरेंस ही क्या रह जाएगा? 3 cycle और 2 सब एक ही डिफरेंस है ना. So I think मेरे को भी पर्सनली लगता है कि 1 cycle, if you are treating stage 1 is because we are preventing the toxicity for additional 2 more cycle. So all blue की cumulative toxicity, cisplatin, and even unfortunately those patients relapse from the 1 BP दिया है. We can effectively salvage with 3 cycles. So some majority of the patient will not receive 1 more cycle of chemotherapy. So that is one basis. 1 और 2 का difference only 4%.
Early stage 1 seminoma, those are at a local place undergoes total organ. No disease elsewhere.
So the Western world में total organ होती नहीं है, देखो data ही available नहीं है. What we do in our scenario and what we practice also, अगर हम stage 1 में carboplatin दे रहे हैं, so theoretically if it prevents the contralateral testicular cancer, theoretically it will also kill the tumor cells which are present in the scrotal incision also. So we generally do not consider for, if we are planning for RT, then the strip for the scrotal incision that we cover. But in day-to-day setting, if you are giving for, in those patients, we might consider for 2 cycles of carboplatin rather than 1. But routinely with carboplatin, we don't consider for the RT to the sputum.
Thank you.
Thank you.